Good evening and happy 2019. I'm Dr. Janet Bodley with Sunnybrook's Board of Directors, and it's my pleasure to welcome you to the Sunnybrook Speaker Series. It's a new year, and we are really excited about the lineup of talks we are preparing for you. Over the next few months, we'll be covering heart health, concussions, and colorectal cancer, just to name a few. As always, you can sign up on our mailing list or check out the Sunnybrook website for details on all the dates, topics, and speakers for 2019. Tonight, we begin with a discussion about incontinence. In my position as a staff obstetrician gynecologist and urogynecologist, this is a health issue that I am very familiar with. As you will hear from our panel this evening, incontinence can take many forms and have different causes, and the impacts on daily living and quality of life can be very real. While a large proportion of Canadians are affected, the Canadian Continence Foundation says many people are still hesitant to talk to their doctors about incontinence or to seek medical help. Thankfully, there is a lot that can be done to help those affected, and tonight we have a panel of leading Sunnybrook experts to guide us through. Moderating tonight's discussion is Larry Jackson. Larry is the Pharmacy Clinical Coordinator in the Veterans Center. Over his 38-year career at Sunnybrook, he has maintained a keen interest in geriatric care. First, in the acute care part of the hospital, working on the geriatric assessment unit, and now in the Veterans Center. He is a collaborator with the Toronto Regional Geriatric Program on the development and promotion of the polypharmacy section of their senior-friendly toolkit. His contributions to patient care, safety, interprofessional education, and teaching at Sunnybrook have been recognized by the Schulich Award for Nursing and Clinical Excellence, as well as the Alan Knight Lifetime Achievement in Teaching Award. That's amazing. Please welcome Larry to the podium to get the talk started.
Thank you so much, Janet, and thank you all for taking the time to come this evening. We are experiencing severe weather tonight, which has affected our in-house attendance. But as always, we're webcasting, so hello to those of you who are watching this event remotely. Our lecture tonight is called Managing Incontinence. The term incontinence can refer to loss of voluntary control over bladder or bowel function. This is a topic many of you have been asking to hear more about. So we're very pleased to have a great lineup of speakers this evening. Sue Sebastian will start by discussing the social and physical aspects of bladder and bowel health. Stephanie Chadwick will follow with a discussion on diversions and wound care. And then Dr. Louise-Hélène Gagnon will tell us more about prolapsed bladder and surgical options. So to get us started with the speakers tonight, I'd like to introduce our first speaker. Sue Sebastian is an advanced practice nurse and nurse continence advisor. She is currently a member of the Corporate Wound, Ostomy, and Continence Steering Committee. Her interest in continence came in 1996 when she was seconded to a 6-month position to work on the elimination standard for the Veterans Center. Since then, she has completed a nurse continence advisor course from McMaster, and her work in this area has continued through conferences and creating the new Veterans Center continence standards. Please welcome Sue to the podium to tell us more about the social and physical aspects of bladder health.
Good evening, everyone. I would like to present this topic entitled Coming Out of the Closet, Urinary and Fecal Incontinence. And for this presentation, I would like you to look at my objectives. I hope to raise awareness of the social, emotional, psychological, and physical impact of urinary and fecal incontinence. I would like to illustrate the impact of these conditions on quality of life, economic productivity, and healthcare resource use. I also would like you and I to listen to the voice of persons who are suffering with incontinence. And lastly, I would like to demystify some of the myths surrounding incontinence. The next couple of slides elicit true and false statements that people have often wondered about. The first statement is, incontinence can happen at any age. This statement is false. Incontinence in older people is normal. This statement is false. Women have urinary incontinence more than men. It's true. A prostate can enlarge with no symptoms felt. Yes, that's true. Incontinence during pregnancy is normal? No, it's not normal. Main cause of urinary incontinence is urinary tract infections? No, that's not true. The loss of muscle tone in the pelvic muscles holding up the bladder can cause urinary incontinence? Yes, that's true. Drinking more fluids leads to urinary incontinence? No. Surgery is the only way to cure urinary incontinence. Not necessarily, so it's a no. The next 10 slides have to do with answering what are your risk factors. The first one is for men. If men have regular prostate exams on a regular basis, say yearly, the risk factor is very low. For women who've had 3 or more babies, the risk factors for incontinence is high. For persons who drink caffeinated beverages, 3, 4, and even more, the risk factor increases and is very high. And for people who are constipated, if they're very often constipated, the risk factor is very high. For people who've had infections in the bladder, or the urethra, or the vagina, or prostate, the possibility or risk of infections is even high if the infections occur very often. If you're holding your bladder longer, let's say 20 or more minutes, the chances of urinary incontinence is a high risk factor. And if you're drinking alcohol often or always, guess what? The risk factor is very high. And how many glasses of water do you drink in a day? If you're only drinking 1 or not even 1, your risk factor is very high. How many times do you void? If you're voiding more times, like say under 1 hour, your risk factor is high. How often do you void during the night? If you're voiding more than 3 times a night, then most likely your risk factor is high. Can you easily get to any toilet when needed? If you're never able to, obviously you're at high risk. Have you had any surgery in the abdomen, in the perineum, or any prostate surgery? If you've had 3 or more, your risk factor is very high. If you've had prescription drugs over the counter, say 3 or more, again, your risk factor is high. And of course, if you are a smoker, you are at high risk. And if you're overweight, you're at high risk. Any changes to your health in terms of diabetes or thyroid problems will increase your risk, as well as any changes in hormones for women or men. It will increase your risk. So all these risk factors can cause, or I could say cause, incontinence. So what is incontinence, and what's the prevalence of incontinence in Canada? The International Continence Society defines urinary incontinence as involuntary leakage of urine. And it defines fecal incontinence in a very broad definition in 2010. In 2010, they defined it as involuntary loss of feces, which could be solid, could be liquid, or passive soiling, without sensation or warning, or difficulty wiping clean, or even coital fecal incontinence occurring during vaginal intercourse. So in terms of prevalence of urinary incontinence in Canada, in 2014, the Canadian Continence Society of Canada has estimated 3.5 million, or 10%, of Canadians suffer some form of urinary incontinence. The ratio is higher for women. It's 1 in 10 as opposed to 1 in 20 for men. So incontinence could range from age 18 to 90 and over, and most of that incontinence in that age group is attributed to one type called urge urinary incontinence. And we see that that occurs in 13% of men and 15% in women. In the chart which you see there, you may not see the provinces. There's a spread of provinces of British Columbia, Alberta, Saskatchewan, Ontario, Quebec, and the Atlantic provinces. In terms of urinary incontinence caused by an overactive bladder, for men age 80, age over 40, the increase of urinary incontinence with an overactive bladder is 15 times more. And for women, it's only 6 times more, only for women who are 75 years and over. When I talk about overactive bladder, you can see from the diagram on the far right, the bladder muscle is squeezing and it's not allowing the bladder to fill up completely. So a lot of Canadians have this overactive bladder syndrome. You see in this diagram, the faded blue indicates stress urinary incontinence, and then we have a larger circle that overlaps it, and that's overactive bladder. Now, overactive bladder could result in urinary incontinence, which is urge urinary incontinence, and that occurs 37%, whereas the remaining 63% of people with overactive bladder can remain dry. Overactive bladder can also result in stress urinary incontinence as well in women. Here is a gender comparison. You see on the far left, the female portion, larger portion is related to stress urinary incontinence. And the other portions are, the red is urge, and the green is mixed. Mixed simply means anyone who has symptoms of both stress and urge will have mixed urinary incontinence. For men, we don't have the mixed urinary incontinence as per strict definition. But for men, they do have stress incontinence only if they've had their prostate removed, and it could be not only doesn't have to be a permanent stress incontinence, but with the damage to some of the sphincter muscles, there is stress urinary incontinence for men, but that's very rare. The main type of incontinence for men would be overflow, and that's related to the next slide, which I am going to show you. This is just a schematic, simple illustration of what urge incontinence does, what stress incontinence does, And again, these stress and mixed together make up the term mixed symptoms. Now in this diagram on the far right, you see that the bladder is full of urine, and that's what we call overflow. The bladder becomes very full, and you know that the prostate is somewhat larger than the one next to it on the left. When the prostate enlarges, it kind of squeezes the urethra, which is close to the bladder outlet, and the urethra becomes very narrow at that point, and urine can only escape, and what cannot escape is retained. So that's overflow, and the result would be urinary retention. That occurs in men, and usually occurs in men age 65 and over. And when men reach around 70, the literature says that men also have a complex condition. Besides overflow, there's also urgent urinary incontinence. So they both have those two, but we don't call those two mixed urinary incontinence for men. Another type of incontinence which we see will be in younger children, what we call bedwetting or nocturnal enuresis. And it happens for children ages 3 and maybe 5, those who are ready to be potty trained. And it's explained that maybe their bladder is still immature. And sometimes it could be between 10% for children even over age 5, but it occurs occasionally. Now, bedwetting in adults, again, is nocturnal. It occurs because of loss of control of bladder, and it's usually the result of several medical conditions as listed in this slide. Another type of urinary incontinence, which happens for both men and women, would be functional. And functional means that it has nothing to do with the bladder, but it has to do with, are there enough toilet facilities? Can I get to the bathroom, which is located at the far end of the room? Or maybe I have a psychiatric problem, or I'm depressed. I don't want to go. I'd rather do it in my incontinence brief, or sometimes it's related to medications. In talking about the prevalence of fecal incontinence, the literature says that it occurs in 40% of those who have urinary incontinence. One literature source says that it's estimated to range from 11 to 15%. Like urinary incontinence, fecal incontinence is underreported, and usually 1/3 of the people who have symptoms of fecal incontinence, only 1/3 will report it to their family physician. So you can see why it's so unreported. Even 11 to 15% is kind of low. For fecal incontinence, we can include just fecal soiling, and it could happen occasionally, and it's usually at 20% of people. Complete loss of controlled bowels is less common. People under the age of 65, the prevalence is only 1%, and people over the age of 65, it could range between 4 to 7%. Younger women, surprisingly enough, it'll be 3 times more likely to have fecal incontinence before the age of 65, and then it balances out for both men and women after that age. And for women who are much older, it could be 8 to 1, 8 for women and 1 for men. Prevalence of fecal incontinence, again, I said, why it's so prominent in younger women. It's because of difficult child birth, Pelvic organ prolapse. It could be in the form of a cystocele, uterine prolapse, or rectocele, and those also with urinary incontinence. Also, it's high with the elderly and persons with poor health status or physical limitations. And of course, fecal incontinence is high for those residing in long-term care facilities, especially if they are bedridden. The main types of fecal incontinence recorded in the literature are 3 types. One is overflow, and overflow is simply impacted fecal matter. That's constipation. Reservoir fecal incontinence occurs in patients who have diminished colonic or rectal capacity. It could be related to impaired rectal sensation, or it could be hypersensitivity as a result of inflammation or irritable bowel syndrome. Then we have the 3rd type, which is rectal sphincteric fecal incontinence, and that has to do with any structural anal sphincter damage or dysfunction. In this slide, you'll see that there are patients who have internal anal sphincter dysfunction and those who have external anal sphincter dysfunction. So patients that make up IAS, which is the internal, is 63%, and patients with the external anal sphincter would be 44%. Surprisingly enough, only 26% of persons have normal anal sphincter dysfunction. As people age, usually the internal anal sphincter, the tissues tend to be thicker, and the tone is less strong, and so there's more fecal soiling occurring. The common cause and risk factors for fecal incontinence is a whole slew of medical conditions, as you can see in this slide. And one of them, as I mentioned, has to do with the anal sphincter dysfunction. Any anorectal pathology, or even anything congenital. We had a speaker who spoke in Rome in 2018. I don't know if you know this TV speaker, Derek Fage, who was born without an anus. And so with surgery, it was corrected, but the result was he had lifelong fecal incontinence. Rectal anagenesis means that the rectum is not fully formed, and myelomeningocele seal means that there's a cyst or imperfect structure of the spinal cord that impairs the brain function to the bladder and bowel. And of course, the other would be diarrhea, environmental, and all the others that I've listed in this slide. So what I'd like you and I to look at is how do others view incontinence? Because how they view it carries an enormous stigma for them. Here is what incontinence for many people. It carries a serious emotional toll. And one literature says that women who live with incontinence are more likely to suffer from depression. And that urinary incontinence, along with Alzheimer's and stroke, are the 3 chronic conditions that most adversely affect a person's health condition. Here is a gynecologist who specializes in urinary incontinence in women, and this person says that this is a common and distressing problem for women after childbirth. And many patients have told this gynecologist that they can no longer exercise, play with their children, attend Sunday school or teach Sunday school, go to church, or have relations with their spouse. Here's someone who had rectal cancer at age 47, and it's been almost 9 years since he found the tumor. He had radiation, chemo, and surgery, and he had a temporary colostomy. After that was reversed, he was left with fecal incontinence for many years and would not leave his house for over a year and a half. So he was virtually a shut-in, and he was having constant fear of an accident. Here's another story of a woman who's age 45, a mother of 3, incontinence for 20 years, and suffering from depression. And I guess this is the one who taught Sunday school, and sang in church. And with one accident behind the pulpit, she was so embarrassed that she just would not go out. Here is someone who says, the doctors have been very, very good. They've been great. But they are at times at a loss, as well as I am, and they don't know where to turn anymore. I'm not alone, but sometimes she feels no one understands her. Here is a man who's 71 years old, and all his life, no one has ever had to help him with his toileting, but suddenly his son has had to help him. And so he said, with this, I lost my dignity. And that's the theme of the next story. You have very little dignity when you're incontinent. Here's one of the last two stories. Here's a person who is reluctant even to tell his or her best friend. And here's someone who would rather live with incontinence than live with the medications that has dry mouth side effects. So these are the voices of people who are suffering with either urinary or fecal incontinence. So in terms of the financial economic impact, for over the out-of-the-pocket costs, the Canadian Continence Society estimates $1,400 to $2,100 a year that a senior has to put out, or a family helps a senior, puts out in terms of incontinence products. It could be additional laundry and dry cleaning, additional toilet paper, paper towels, medications not covered, and home care services. The next 10 slides just illustrate the cost in terms of out-of-pocket costs for men and women. And in Canada, this is 2011 census. For Canadian women, the out-of-pocket costs is $1.75 billion. For men, it's $829.5 thousand. But for a total out-of-pocket cost for Canadians in 2014 amounts to almost $2.6 billion. In terms of the cost to employers, here's data for 2013. The women in the labor force and for men in the labor force. For women, or total employees with incontinence, both men and women, it would be 915,000 workdays a year. In terms of days lost, it would be 11.5 billion workdays. And that's the summation of those who are absent from work because of incontinence and those who are present at work. And this is called presenteeism. That means they're at work, but they're not fully there because they have to be excused to go to the washroom. They have less concentration. Most likely they're depressed. So they're not putting in a full day's work, but they're actually there. And that's added to the days that they're absent. For the employers, it's a total cost of $2.1 billion. In terms of annual cost to the healthcare system, is $3.84 billion. And we can see that at the very last, $3.843 billion. The last part has to do with how does it affect the direct medical costs. And here's a breakdown from that $3.8 million. The direct medical cost per person would be $10,409 annually per person who would be visiting a doctor. Increased visits to family physicians would be $77.20 a visit. And for those in nursing homes, it would be about $10,000 or more annually. For those living in long-term care facilities, it would be $161 daily per resident. So you can see that the combined direct and indirect costs of both urinary and fecal incontinence is quite enormous. Total cost is $4 billion. If we say that 2.6 is urinary incontinence, then you subtract 2.6 from 4 billion, and we could say that 1.4 billion is attributed to fecal incontinence, direct and indirect costs. So the cost also, when we look into the future, there's a cost as well. The literature says that 9.6 million Canadian baby boomers are going to be diagnosed with incontinence. An estimated 30 to 40% of those aged 75 and older will suffer from the most common type, which is the urge urinary incontinence, and that a key factor for someone who's a senior moving from their home to long-term care is usually urinary incontinence or incontinence in general. So the conclusions, I hope that with this presentation, I have raised your awareness of the social, emotional, psychological, and physical aspects of incontinence, both urinary and fecal. I've illustrated the impact of these conditions on quality of life, economic productivity, and healthcare costs. And I've given you the opportunity to listen to some of the voices of people suffering from incontinence. And I hope I have defied the myths surrounding incontinence. So what are the take-home messages? I only have 7. The first one is urinary and fecal incontinence are truly complex and they're costly medical conditions. The second one is that urinary incontinence and overactive bladder for both men and women comprise 2 of the 10 most chronic conditions. And that supersedes hypertension, depression, or diabetes. And I could say it even supersedes dementia. Urinary incontinence and overactive bladder impact the lives of men and women psychologically, occupationally, domestically, physically, and sexually. And also increases the care burden. The fourth message is that symptoms of urinary incontinence and fecal incontinence are both underreported. Why? Because individuals feel the current treatments are ineffective. Symptoms are a normal consequence of aging, so nothing can be done, or it could be normal consequence of childbirth, so nothing can be done. Or they think it's truly embarrassing, too embarrassing to talk to your healthcare provider. So the next take-home message is that a coherent strategy ensuring access, the key is access, to various treatment options will help reduce the overall cost and the individual impact of incontinence. And also to let you know, there have been significant advances made in the management and treatment of incontinence. Treatments that could be behavioral, new medications that are more effective and have fewer side effects, and also new advances in surgery. Professional organizations, government agencies, and consumer groups worldwide have developed practice guidelines to both urinary and fecal incontinence. And also, lastly, direct-to-consumer advertisement has helped people to become more informed. Thank you very much.
Just wait a second, Sue. I might just do questions now,
Sure.
just because the audience is so small. Okay. Thank you very much, Sue. Just because of the storm has affected the number of people who were able to attend in person, it might be best if we just took questions now. If there are any questions for Sue, she could answer them now, and we could then move to our next speaker. Any questions from our in-house audience? No. Okay, thank you.
Okay, maybe I can ask a question. Anything new that you've learned? Just one answer. Or is this old stuff?
Yeah.
Christabel. I learned that there's 2 types of incontinence. There's 3 types. 3 types. Okay, good. Thank you.
Okay. Thank you, Sue. for your wonderful presentation. I'd like to now introduce our next speaker. Our next speaker is Stephanie Chadwick. Stephanie is a nurse practitioner in the Wound, Ostomy, and Continence in the Oncology program at Sunnybrook's Odette Cancer Center. This program provides consultation and education for ostomy patients in-house and through the various patient clinics. We are very fortunate to have and pleased to have Stephanie with us tonight to discuss diversions and wound care. Please give her a warm welcome.
Thank you very much, and thank you, Sue. So tonight, I've changed my discussion a little bit because I wanted to merge and be able to assimilate the importance of incontinence and be able to discuss that with all of you. And complementing Sue's presentation, she's already given you that dynamic experiences of what patients have felt and what people living with incontinence feel and live with on a daily basis. And also, she's discussed the prevalence and stats for us. So my presentation will be opening the door to incontinence and understanding diversions. So as we've known, and Sue has stated, urinary incontinence, unintentional involuntary loss or of urine or of stool. We can today look at the fact that what I'd like to discuss with you is make you more comfortable and understand urinary incontinence, understand fecal incontinence, and then what exactly is diversions. As we know, 3.5 million Canadians experience some form of urinary incontinence. Urinary incontinence is the most common form of incontinence, impacts quality of our life, and frequently it will cause visits to the family physician and hospitalizations. Women are twice as likely to experience depressive symptoms when they have incontinence. What I found with incontinence is there's a strong economic burden, and especially it is more cost of that individual. They're out-of-pocket expenses, and that's just expenses alone. We're not talking about the quality of life at this point or the impact that it has on their family members, their friends, or others that are with them. We have to look at supplies, different types of products, catheters, condom catheters, light, moderate, and heavy absorbent pads. We have to look at the laundry expenses, dry cleaning, toiletries, medications. This is just a small list of what a person with incontinence has to deal with. Then there are the medical visits, physiotherapists, psychologists, and loss of productivity. There's several contributors that will go to incontinence, and instead of putting them just equally with their own types of, whether it's stress or urge incontinence, I thought I'd list them so you can have a bit of an insight that there's multiple factors that will relate to incontinence. And if it's not the fact that it's causing that fact, it is part of a contributor that will cause incontinence. So we have diabetes mellitus that will affect your nervous system and can affect your messaging from your brain to your bladder or bowels. We have pregnancy, which has been mechanical trauma to the bladder, and again, issues with that. There's childbirth, menopause, our estrogen loss, vaginal atrophy, vaginitis, urethritis are a few to mention. And when I speak about menopause, there's a big indicator that women are actually thought about when they're thinking about coming into menopause. They're not told about certain aspects of menopause. It's almost like one of those silent transitions. We know, oh, we don't have our period anymore. However, they don't say what are the other aspects that are going to happen for us. Like as our estrogen levels come down, how are we helping with that? And that's where we need to have a better awareness of menopause and the aging adult, because it's very important, because those factors alone can contribute to leading problems for us. Obesity, as we age or as we move through our transitions in life, we gain our weight. And when we become more enlarged and have heavier weights, this is putting a burden onto our bladder. Constipation and impaction is a high risk factor for leading to incontinence. Urinary tract infections can precede causing urinary incontinence. Smoking is a large trigger, irritant, and other factors that can cause incontinence. Alcohol consumption and depression. And more of the fact of the depression is the symptoms that are associated with having depression and the maybe not wanting to get ourselves to a bathroom to have our urinary or bowel activity. We've just started the list. We look at enlarged prostate, prostatitis, male hormone changes. We look at bladder cancer, that can be a factor, colorectal cancer, pelvic tumors, anything that is impeding on the bladder. Neurological consequences such as stroke, spinal cord injury, multiple sclerosis are other factors. Parkinson's disease, Alzheimer's can cause functional attributes. Psychological disorders can impact our continence. Cancer treatments, whether we've had radiation to the pelvic region, brachytherapy if it's for a person that's having prostate cancer. We look at chemotherapy and medications, polypharmacy, many medications that may contribute to it, and we need to understand what are our medications. We look at surgery in the pelvis, prostatectomy, hysterectomies, rectal surgeries, episiotomies, urological surgeries. Geriatric, we can look at more functional, delirium, restricted mobility. I found when patients become hospitalized, remembering that a person needs to be able to get facilitated to a bathroom, to a toilet, being able to access those instead of having the issues of having incontinence. And fistulas can cause incontinence as well. So I look at a tap that's running and I think, oh my, we have incontinence. Oops. My presentation's not moving forward. I'm in a dilemma. Just 1 second, and I have a paper form if this won't move forward, and I'll carry it on that way. Oh, thank you. That's perfect. Technical glitch. I am definitely not computer savvy. So types of incontinence, as we know, there's the stress incontinence that Susan mentioned, urgency incontinence, mixed incontinence, overflow incontinence, overactive bladder, and functional incontinence. And I'm hoping, there we go. So stress incontinence, how many of us have experienced this? We cross our legs, we hope, oh my, don't sneeze again for that third sneeze. I've controlled myself for 2. We might be playing, running and jogging and bouncing and impact of causing us to have a little bit of leakage. Carrying, picking up our child, heavy lifting. If we don't remember to do our Kegeling, we'll have our stress incontinence. And I'm sorry, some of these images are just Google alerted, so I could have a little bit of an image. So they're referenced at the back. So as we said, 50% will suffer from stress urinary incontinence. And this is unpredictable loss of urine. So it may be a large volume, it could be a small volume, depending on our ability of our pelvic floor and our strength that we can have in this area. Urge urinary incontinence, this is where we look at where are all the bathrooms, can I make it to the bathroom, how fast can I get there, and please no one be at the other side of the door. Or in the night, definitely I'm getting up multiple times because I need to get to that bathroom toilet. And as you can see, they're very fatigued. And so again, we have urgency, frequency, voiding small amounts of urine, and nighttime voiding. An overactive bladder, as we can say, can be a combination of urgency and frequency. And it can be during the day and in nocturia with in the evenings, or with or without urgency incontinence. This is where it's not associated with infection or obvious pathophysiology, but it's more can cause fear, potential incontinence, that we're going to have incontinence. And some can have it where they can actually be dry, where we know we're feeling that sensation, we have that urgency, but we can still control. Whereas others will not be able to fully control. They have to sit and pull at the same time to be able to get on that toilet seat. Or some might say, I get up, I feel the sensation in the night, I'll get up, and before I can even get to that bathroom, I'm having my urine flow. So we can get, again, with overflow is that urgency, frequency, poor urinary stream, dribbling of urine after urination, and nighttime voiding. Functional, again, this is where our environmental barriers are causing us the grief, or it can be our cognitive or dementia, where we don't have that realization that we need to be toileted or to get up to go to the bathroom. We're unaware of that remembering to get to do that need. Can be impaired mobility, not being able to get around in a proper room, being the access to get to that area, being bedbound and not being able to have toileting in a timely fashion. And again, medications. So the most important aspect that I always want you to understand when it comes to the subject of why do I have incontinence? And this is the biggest fear, as Sue had stated. No one really wants to talk about it. It's like we live in isolation. What I'm glad to see is we have commercials that are starting to address what products and how we can have it, and different people of different ages will have this issue. However, what they're not saying as well is they're showing and demonstrating that you can live healthy lifestyles by using briefs or absorbent pads, but they're not directly relating to what is the cause and helping you realize that, yes, you need to speak to your healthcare provider. And this is an important aspect. And even though, despite the fact that for some reason we all find ourselves, as soon as it's a part of our body that shows that maybe there's a weakness or that we don't have that independence or that control, we're fearful to say, can I speak to my healthcare provider about this? Or we'll back off and say, oh, I'm doing fine. Or we'll feel we're too rushed to be able to really discuss it with our healthcare provider. When you go to the healthcare provider, we really need to get a good understanding of what's happening with you. We need that history. We need that physical and general health of how you're doing. We look at investigations, and we can look at what other types of investigative management do we need. Is it a simple urinary test to rule out that you've had an infection? Or is it a dynamic study where we have to really look at your ability and your management of what's happening with your bladder? Do we need to do ultrasounds or other images or x-rays? And then we want to talk with you and determine, after we find those facts, then we can sit down and really look and seek out what is a plan or an alternative that we can do for you or accompany you, deciding on what to do with your goals in mind as well. So, initially, with our urinary incontinence, we want to try minimally invasive strategies, especially if it's associated with a stress incontinence. We want to look at, if it's urinary or fecal, and your patient, your goals. What are your goals? And what I always strongly recommend is, if you're noticing you're having issues with incontinence, it's what are the triggers, what's happening. And the best way to prepare yourself to come to a doctor is to keep track. Initially, having a bladder diary or a bowel diary. So you're looking at, how much fluid have I drank? When do I have my incontinence? What time of the day? How frequently? Am I feeling that sensation that I'm fully emptying? Or was there something else that's triggered incontinence? And that's really important, because when you're bringing that information, you don't have to leave your physician and say, oh, I've got to go back, do this, and now come back to my physician or to my nurse practitioner or to my wellness coach. And then we look at symptom screening, especially with men. We want to look at, are you having that prostate enlargement, and screening for that. We want to look at lifestyle changing, and we want to make small, simple goals. If we set out and gave you a list and said, okay, you have this problem, now you're going to do A, B, C, D, E, and whoop, you're going to be perfect. It's too hard to say for anyone, let's do all of this at one time. So let's keep it simple. We'll start some small strategies and work upward depending on what your needs are. And making sure you have that continual feedback and interaction with your healthcare provider. So we look at positive suggestions. A really good one is education, really fostering your understanding so you can understand what type of incontinence do I have? Okay, now what information do I need to know about it? We then will look at, do you need a specialized treatment? Say, for example, learning how to strengthen your pelvic floor. And what I find is having functional assessments, but really linking with the community. We look at physiotherapists who are really dynamic and innovative on helping you learn how to strengthen your pelvic floor. And they'll do an intimate interaction with you where they can really help you ascertain, am I actually really doing pelvic muscle strengthening, or are my abs getting better definition? We look at the nurse continence advisors, urologists, gynecologists, health practitioners, and what specialty you might need. Bladder retraining. We can look at from your bladder diary, is it that you're going to the washroom right at the first urge and not giving you that time, that ability to learn to hold your bladder a bit and distracting yourself. We look at healthy bladder with positive reinforcement techniques, scheduled time voidings, working your way up and increasing the length of time, opposed to when you feel you have to keep going, you run to a bathroom, even if maybe despite just to prevent incontinence. We learn to help retrain that bladder that it can wait a little longer, and you build this time between the times you void. When you're doing that, you're looking at building the capacity again. And you want to make sure you're not pushing when you're voiding. As you're adding that additional push, you're putting that strain on the bladder as well as on your pelvic floor. Trial sitting and then standing and re-sitting, opposed to just sitting, going, running off. You want to try that. And in men, it's trying to sit opposed to just stand. It might give help to add that pressure to the bladder region to help with the sphincter release and relaxation. And then there's distraction techniques, counting before you go, thinking back of different things before you move forward. Pelvic floor exercises, as I said, with the physiotherapist. We want to have that. But there's different ways of strengthening your pelvic floor. There's Kegel exercises, pelvic floor exercises. There's a plethora of different types of exercises depending on what you really need, because not all areas of the pelvic floor might be affected. You might have tightening of ligaments in different areas or weaknesses in others. So that's why you really want that physiotherapist to help you with this. Then there's also where sometimes we'll add vaginal cones at different weights, where you're learning to hold and squeeze to be able to get the different weights. And if you put one in and you can go run a marathon, then you know it's maybe you need to go to the next size up. There's vaginal passeries, which is a non-surgical technique. However, you're going to be having to be fitted for this. You are watched for this. You learn to remove and insert. And then I'm using probably the wrong terminology, but there are forms of different types of tampons that can push and help bring up and prop up the bladder again, so that you can do physical exercises if you need that extra ability to help with that movement. Lifestyle changes. Now this is where we start to move to what do you need to do to really change. Smoking cessation. Are you ready? We have to assess the readiness with each of your visits, because smoking can be detrimental to the bladder and cause irritants to that bladder and lead to incontinence. Alcohol consumption, as we said, is a very high risk. So are you feeling that maybe, are you having alcohol issues with your alcohol consumptions, or is there an area that we can look at? Do you need some form of counseling? And depression. Are you seeking therapy? Are you having support? What are your triggers for your depression? And how are you managing your depression? Again now, which is a very challenging subject and not many people like to talk about it, is weight loss. Simple weight loss can make a large impact on our incontinence. Dietary changes that will help with that weight loss. And then again, other triggers that can be more irritants, and avoiding simple things such as spicy foods, citrus juices, caffeine, and changing to maybe no caffeine, decreasing the amount of coffees in a day or teas in a day, increasing water intake. And as Sue said, if you noticed on her display of high risk to low risk, you're at higher risk when you're drinking less and lower risk when you're drinking more. So you're wanting to make sure that your bladder's not getting to that point where you dehydrate yourself, that the capacity becomes lessened, and then now you need to go because you have that lessened capacity. And exercise. Fearful as we may say, exercise and well-being is always a contributor to healthy continence. So we've talked about also the behavioral and the physiotherapist, but the physiotherapist can look at maybe electric stimulation and biofeedback mechanisms to help you to make sure you're being able to do the right connection when you're doing your training. So other ways of preparing is, what else can we use if we are incontinent? And it depends on how, are you mildly incontinent to are you having heavy flows of incontinence? And sometimes you may require catheterization, where you might have temporary in and out catheters, where you might have to have a catheter put into the bladder where it's associated, where the urine's coming out to lessen the problems with the bladder. There's sometimes external devices as well, like condom catheters that you might manage, especially at bedtime, to help when you're sleeping so you're not having to get up as frequently. Incontinence pads, we're looking at the absorbency. And what's very important is making sure we're selecting absorbent products that are geared for urinary incontinence, not menstrual flow, because they are different in capacity and how they manage the urine. We want to look at washable undergarments or disposable garments. And a big factor is when you're washing your underwear, when you're washing your clothing, is using unscented products and not scented products, even toilet papers that are unscented. Hygiene, you want to use neutral cleansers. Liquid soaps opposed to bar soaps are less harsh for you, making sure you're rinsing tepid water opposed to overly hot water as well. And barrier creams are maybe a needed product that you might need, which you can discuss with your pharmacist. And then there's sometimes forms of toileting devices. Do you need a bedside commode? Do you need a raised type of toilet seat? Do you need a toilet seat that has an opening opposed to a totally full impact to it? There's medical mart stores, drug stores, and you need to really determine the cost, because this can be a very large impact for you. And one big factor is we look at if urinary incontinence or bowels, we're having issues for more than a year, we can look at funding through the tax credit of the government when you're doing your taxes. There's other insurance companies that help with your products depending on if you can get prescriptions and its requirement. And then sometimes we can look at funding through the government, or you can look at industry for support. Now, other factors can be medications, and there's now different forms of medications that you can be used for incontinence management. I didn't list them today because I don't want to cause and start putting a type of product down that all of a sudden pharmacists are getting a ring that I need to have this product. And this is where you want to talk to your healthcare professional, because depending on the type of incontinence, you may need a medication, you may not. And it's the same when you're thinking of herbal medications. I think of a herbal medication as a medication. So if you're seeking and looking at labels and saying, well, I read up that if I use saw palmetto, I'm going to have a decreased prostate and I'm not going to have incontinence issues. But you really need to look at, is that true, or Have you talked to your pharmacist to have a better understanding of what may be other consequences if you've used a herbal medication, and how can it impact your other medications that you're taking as well? So never just go and determine that you want to use a herbal remedy unless you've really talked to a professional about it. There are surgical options as well. And sometimes you need to have surgical intervention, whether it's a different type of procedure to help with the incontinence measure. And this, your surgeon, your family physician, a practitioner can discuss with you. And I always say keep a journal, because if you keep a journal, it's able to allow you to know where's your journey and at what point and where are you, to help to also show you that have I shown improvements with certain managements opposed to other ones. Because we can always say, oh, I'll remember that. But for me, a month ago, it's like, okay, I need to have that written down. So if we move to fecal incontinence, we think of involuntary loss of bowel incontinence. Bowel function requires an anal sphincter muscle control, internal and external, a rectal nerve pathway, and rectal muscle stretch. We can have forms of diarrhea, constipation, loss of sphincter control, nerve alterations, radiation can cause issues, inflammatory disorders, hemorrhoids, prolapse, cancers, and that's just a few to mention. Again, we need to determine the cause, and unfortunately, that means we need to talk to our healthcare providers. Again, they're going to do that history. They're going to want to have a physical examination. They're going to do investigations, and then they're going to help you along your journey to determine what intervention should I be using. Again, we're looking at dietary changes might be the only factor that we need to look at. Bowel retraining factors, biofeedback mechanisms, medications sometimes that we need to take to help with our incontinence, depending if it's diarrhea, constipation, and surgery are sometimes alternatives that we need to have. So that leads me to discuss diversions. And what exactly is a diversion? I look at it and think, okay, well, what do you mean, diversion? Well, let's talk about it. So diversions can be something that's dependent on a disease process. It can be a traumatic event or a combination of a treatment or therapy that you might require a diversion. We look at the fact of your general wellness, both physically and mentally. We also look at where is a diversion going to have to be anatomically placed, and how is that going to alter with your body habitus. We look at, is this going to be improved your quality of life or a survival, and the complications of having a stoma, what could happen. We really need you to understand the education and the understanding of having a diversion, and your ability to self-manage, or are you caregiver dependent? And again, cost of products to you and resources. So types of diversions, they can be urinary or fecal. Now, if we think of a diversion, it's a surgical created opening within, for the urinary system. If it was your bowels or intestinal system, it would be a gastrointestinal system, So we look at urine, and if we think about a urinary diversion, there can be continent diversions, there can be incontinent diversions. And what we're looking at is, when do we need to have improvement to the bladder or removal of the bladder, and we need to lead the urine from our ureters to a different path. So if we think of a way of when we need to take the urine and bring it to the surface of our abdominal area, we can be looking at what's called an ileoconduit. And something like that means that they're forming from your small intestine a channel that comes up to the surface of your abdomen to form a stoma. And what you're going to see is, from there, if we think of our bladder, we have our kidneys that produce our urine. We have ureters that come down to allow that urine to come down from the kidneys to the bladder. Well, those ureters are now released from the bladder and need to go into what we have, this little intestinal a region that's built up and brought to the surface of the skin. And when they're doing that, the ureters are reimplanted into that little segment of intestine. That segment of intestine still has a blood supply from our mesentery, but it's no longer going to be really directed with the fecal that's coming through there, your stool. So we have this little stoma that comes to the surface of the abdomen. This area will allow urine to pass. And if we think about that, initially, what would you see? You're going to see a very swollen area of intestine at the surface of your abdomen, and it's the inner layer of the intestine, of the small intestine that you're seeing. It will be moist, very swollen initially, and it takes time for that swelling to come down. To protect the ureters and where everything's been sewn, you'll have 2 little stents within that area for the first 4 weeks. The stoma itself changes over the next 6 to 8 weeks in size. What you'll find as well is, because we've had a creation of a stoma to the anterior aspect of our abdomen, you're going to see the change initially from the urine as well, because you've had a surgical procedure. Not to be alarmed, you'll have blood, and you'll also see mucus. And the reason for the mucus is because it's coming through from the intestinal aspect. What you'll find is, slowly, as you have more hydration and the urine passes through this area, you'll start to have more and more and lessened mucus and more of a urine color. Now, because urine's coming out of this area, we use what's called an ostomy appliance or a urostomy appliance. And that is a wafer that goes against your skin and a pouch that has the urine able to come into the area. Other times, you might need just restructuring of the bladder, where they can make a continence stoma. And they're taking a section of the bladder, building up the capacity of the bladder, and bringing, again, a little section to the surface of the skin to be able to pass your urine. And this would be a type that you would catheterize. So fecal diversions are surgically created opening from the gastrointestinal tract, and that again is brought up to the surface of the abdomen. Now, anatomically, if we think about our gastrointestinal tract, right from our mouth all the way down our esophagus to our stomach, to our small intestine, our large intestine, down to our rectum and anus is our gastrointestinal system. If we have a diversion of colostomy, we're looking at the large colon for having a diversion. If we have it from the small intestine, you're looking at an ileostomy. Now, this will be, again, you'll have your stool coming from these areas. But depending on the location, the type of ostomy you have, it's a colostomy, you might have more of a formed stool, from a softer to formed stool. However, you may go from have a routine bowel functioning to every 1 to 2 days, or you may go several times in a day. That's why we use, again, a wafer on the skin and a pouch on the abdomen. And there is a plethora of different types of appliances that we will be able to use and different strategies to manage a colostomy. Whereas if you have an ileostomy, your stoma is created and comes out from the small intestine, and your output, because it's not going all the way through the process of being able to go through the large colon, the output doesn't have the absorption of the water or the salts, so our output's going to be more of a liquid output to mushy consistency, but never formed stool. And again, why we're using a fecal diversion appliance to contain our stool. So there's different aspects to learn about when you have an ostomy created. So I always think we want to keep everything simple. Having a stoma created doesn't mean that now we are going to have a poor quality of life. It might impact and improve your quality of life, and especially if it's a factor because of incontinence management. But if it's a factor for between treatments or permanency, what we need to know is we keep it simple. So you can still have a good quality of life. You still can be active. You can still shower. You can still swim. You can do your sports. You can learn to manage and accommodate your change of how you take care of yourself. You can, because you can shower, it's going to be simple. You can shower with appliances on or appliances off. Skincare is basic, water and cleansing the skin with paper towel. And fortunately, our stomas take care of themselves, so you don't have to worry. However, they have no nerve endings, so we have to watch that we're not scratching them or banging them. But that is something that you would learn in your journey of having an ostomy created. And what I find with an ostomy creation is, where's your wellness? How are you feeling? Your body image, and adjusting to the fact that you have a change in your anatomy. So when I think about someone that has an ostomy, we want to be able to see you prior to surgery. We see you during your transition of having surgery, and follow you after surgery as well to help be a support for you. There's community nurses that will also be there for you, and industry also is there as support. And there are numerous different companies that are there to support you in your transition and when you're having an ostomy. We look at also your funding. Do you have funding from insurance companies that will help with the cost of offsetting costs? Or if it's a permanent ostomy or something greater than 6 months, we look at funding through the government to help with support. In the community, we help provide some product, and as well from the hospital. However, eventually you are buying products, and these can be simply bought through Shoppers Home Health, Medical Mart stores, online. A lot of people are buying products. And it's that, once again, what am I comfortable with? What do I want for myself, for my lifestyle? So we want to reduce your barrier to communication. We want to prevent you living in silence and isolation. We want to improve and take away embarrassment, decreased self-esteem, feelings of being ashamed, and loss of your independence. Having an ostomy creation, you are very independent.
Please retrieve an important message from the printer.
And we work,
Attention, please. Your attention,
sorry.
please.
We work to help you form your independence, because having an ostomy is just going to be a different way for you to have your urine or your stool passage. It doesn't mean that it's going to change your ability to be able to continue on with what you've been doing previously. We look at, what I always look at is education. With education, we become less stigmatized, and we look at the fact and rationalize that this is something that is okay to have. I want to look at lobbying, because this is where I find we really need to work as a team and increase for funding, better supports for patients that have incontinence, that have requirements for ostomies. And after that, I'd like to say thank you very much.
Thank you, Stephanie. I might just ask now if there are any questions for Stephanie from our audience that has come this evening. Okay, thank you very much, Stephanie. That was a wonderful presentation. I'd like to now introduce our final speaker. Dr. Louise Hélène Gagnon is a surgeon in the Division of Urogynecology. She is a McGill University medical graduate, and since then has completed training in obstetrics and gynecology, as well as female pelvic medicine and reconstructive surgery and urogynecology. Dr. Gagnon's research interests include surgical outcomes of urogynecological procedures. It's wonderful to have her speaking this evening. So please give us a warm welcome as she comes to the podium to speak about bladder and surgical options for bladder, prolapsed bladder. Thank you.
Okay. Okay, so this is going to be a short presentation, 15 minutes. I'm going to talk about incontinence and prolapse. I'm going to skip over the slides that go over definitions and prevalence, because we've looked at that already. I'm a urogynecologist, so I deal with women. I don't deal with men, so this talk applies to women. Some of the principles do apply to men, but don't ask me questions about incontinence in men, because I won't be able to answer. So I'm going to talk about stress urinary incontinence, overactive bladder urge incontinence. We talked about that already a little bit. I will talk about prolapse because I see a lot of patients with prolapse, and we often see patients come in with incontinence and prolapse. And I'll talk about surgical options for all of these symptoms and pathologies. So we talked about this already. I won't go over definition and prevalence again. The two most common types of incontinences are stress incontinence and urge incontinence, and when you have both, it's called mixed incontinence. There are a lot of patients who come in with mixed incontinence, so we have to kind of separate the two because they're treated completely differently. So when I teach trainees about the difference between stress incontinence and urge incontinence, I say stress incontinence is leaking when you cough, laugh, sneeze, jump, run. Urge incontinence comes with the acronym FUN, so frequency, urgency, nocturia. Frequency means you go to the bathroom more than 8 times during the day. Urgency means you get that strong urge to pee and you don't have a lot of time to make it to the bathroom. And sometimes you leak on the way to the bathroom, that's urge incontinence. And then nocturia is going to the bathroom more than 2 times at night. So 0 to 2 is considered normal, but over 2 is too many times. So stress incontinence. So this is the typical lady that I see coming in my office. She's a 55-year-old lady. She leaks urine. Her name is Louise. She's been having more frequent episodes and larger leaks. She leaks mostly when she sneezes or exercises, and she doesn't have urgency or frequency. She doesn't have issues with voiding. She doesn't feel like she doesn't empty her bladder completely after she pees, and she doesn't describe symptoms at night. She doesn't describe prolapse, and she is sexually active, and she does leak with intercourse. So stress incontinence typically occurs from injury from vaginal deliveries, okay? Almost every single patient that I see with stress incontinence has had a vaginal delivery. And the reason is that women lose, and I want to just show this. Okay, so women lose all the kind of strong connective tissue that's sitting around the urethra here. And then the urethra becomes what we call hypermobile. So when there's nothing kind of strong to hold the urethra in place, when you have an increase in intra-abdominal pressure, there's nothing strong for the urethra to close on. So with surgery, what we try to reproduce is that strong layer of connective tissue. And I'll talk about the different surgeries that we can do to help women with that. So I always talk to women about conservative options and surgical options. Some women do not want to consider surgery, and that's okay. And when we talk about conservative options, we talked about lifestyle changes already. We talked about pelvic floor physiotherapy already. I'm happy to elaborate in the question period. Continence pessaries is really the big way to help with stress incontinence in women who do not want surgery. And continence pessaries look like this, okay? So they look like they're rings that go inside the vagina, and they have knobs. And the knobs are what sits just under the urethra and what supports the urethra so that when women cough, laugh, sneeze, they have support, okay? Surgery, there's essentially 2 big types of surgery for stress incontinence, and they're mostly mesh surgeries that we do, okay? So it's the most common type of surgery for stress incontinence is called a mid-urethral sling, and there's different types. There's a retropubic sling here that we're seeing here, and there's a transobturator sling. It's a ribbon of mesh that sits under the urethra, and that ribbon of mesh scars into the tissue so that when people cough, laugh, sneeze, there's kind of this strong connective tissue layer that sits under the urethra so that it's something strong that it can close on, okay? There are issues with mesh. I won't go into problems associated with mesh, but some women decide they don't want to have mesh done. And for those patients, we have the option of a fascial sling, which is when we harvest patients' fascia and use their fascia instead of mesh. So it's their own tissue that forms the mesh under the urethra. And the second option is what's called a laparoscopic Birch procedure, and that doesn't use mesh, and that's a laparoscopic procedure that we do that uses sutures on each side of the urethra so that the urethra is kind of held in place. And when women cough, laugh, sneeze, the increase in intra-abdominal pressure is translated to the urethra, but because it's held in place properly, it will close, okay? So it is no longer hypermobile, okay? I want to talk about laser because laser is kind of becoming a big thing now for stress incontinence. So we got a huge grant from the Canadian Institute of Health Research here at Sunnybrook. We got $500,000 to conduct a study that may revolutionize the way we treat stress incontinence. So the study is looking at the use of laser in treating stress incontinence. So what we're doing is we're lasering the area just below the urethra. And the laser causes micro injury to the tissues below the urethra. And so it stimulates the body to produce connective tissue, okay? So it's kind of it's a way for the body to, on its own, do what we would do with mesh or do what we would do with a fascial sling or with a Birch procedure. The study is a randomized controlled trial, double-blinded. So that means patients who enroll in the study are randomized to being either in the laser arm or not. If they're not in the laser arm, we disclose to them that they didn't get the laser, and then we offer it to them at the end of the study. And then they're asked to fill out questionnaires to tell us how they're doing and what is happening to their incontinence. And it's going to be the first study that's bias-free. So there's all these small studies that are showing promising results with laser. Laser's now offered in private clinics. It's about $3,000 per treatment, but at the hospital here it's free. So anyway, so for those of you who are thinking you might be interested in this, Sunnybrook's the only hospital in Canada offering this, and you have to enroll in the study. You can ask to be referred to Sunnybrook to hear more about it. Okay, so the second type of patient I see. Now this is a slightly older Louise, so she's 75 years old and she's also leaking urine. But this time, she doesn't leak with coughing, laughing, sneezing. Instead, she voids every hour. She has very short notice to void. She doesn't have difficulty with voiding, but she often has to go again a few minutes later. She's up 2 to 4 times every night. She has a tendency to irritable bowel syndrome, which we often see in patients with overactive bladder. She's not sexually active. She has no pelvic pain. So again, we saw there was frequency, there was urgency, and there was nocturia that we described in that case. And that's overactive bladder. And overactive bladder, as it progresses and as it gets worse, turns into urge incontinence, okay? And overactive bladder is the same as an oversensitive bladder, okay? Overactive bladder is treated with lifestyle changes, bladder retraining. I won't go into that because we did hear who talked about this? Is it Stephanie or Sue? One of the two. But once we've tried all these conservative options, we usually move to medications. There's 2 types of medications. They're antimuscarinic, anticholinergic medications. Those have more side effects, so they're associated with dry eyes, dry mouth, constipation. Adrenergic medications are a newer class of medications, and they have much lower side effects, so I usually will start patients on those medications instead because they're better tolerated. And when patients, I just want to go back to it's in the next slide. I won't go into neuromodulation because that's a rarer treatment, but when patients fail medications, when they failed multiple medications or they haven't improved with medications, my last resort will be bladder Botox. Okay, so that's where I inject the bladder with multiple injections of Botox. Botox in the bladder is the same thing as Botox in the face, so it paralyzes muscles. We don't want to give too high a dose that the bladder is completely paralyzed. We want to give just the right dose so that the bladder is less active and patients don't leak, but that they can still go to the bathroom. And finally, 70-year-old with a vaginal bulge. So this is the prolapse part. So this is a woman who feels like she's sitting on an egg. She can feel a bulge when she's wiping. She sometimes feels her bladder doesn't empty properly. She doesn't have urinary symptoms. She's rarely sexually active. She feels the bulge is in the way, and she doesn't have pelvic pain. So the next slide is pictures showing prolapse. So for those of you who don't really want to see it, you can look away. But this is what prolapse looks like. So prolapse is like a vaginal hernia. Okay, so at the first picture, you can see what's called an anterior wall prolapse. In the middle picture here, you see what's called a vault prolapse. And in the third picture, you see a posterior wall prolapse. So prolapse affects about 3% of women. 3% of women are going to actually seek treatment for prolapse. So it's not as common as incontinence, but there's a lot of stigma associated with prolapse. A lot of women don't consult a physician for a really long time. There's a lot of risk factors. By far, the biggest risk factors is parity. Parity means having children. Childbirth is also the biggest risk factor for developing prolapse over time because it injures tissues, it avulses muscles, and it tears fascia in the vagina. And there's two different options for prolapse. There's conservative options. So again, we can try the pessary that lifts tissues, or we can move to surgical options. And surgical options, I always divide into obliterative and non-obliterative. So I'll explain what I mean by that. Obliterative is equivalent to a closure of the vagina. So that's reserved for much older women who are no longer sexually active. Non-obliterative, I do in patients who are younger and who want to retain sexual function. And the big difference is that both procedures have different success rates, okay? So I tell people pelvic organ prolapse is a hernia in the vagina. It's analogous to having a hernia on the belly. If you have a hernia on the belly, you go to surgery, we close the hernia hole, you have a much better chance of having that hernia not recur than if we left that hole open. So it's the same thing with the vagina. If you leave the vagina open, women are vulnerable to risk factors after that, and there's a 30% risk of recurrence. If women are not sexually active, I'll go with a vaginal closure, and if they are sexually active, I talk about either a vaginal approach for repair or reconstruction of the vagina or an abdominal approach. This is what a pessary looks like in the vagina when we kind of lift things so they don't come down again. And for the vaginal approach for pelvic organ prolapse, what I do is I take out the uterus, I reconstruct the vagina, and then I attach the vagina, the top of the vagina, to ligaments in the vagina, the sacrospinous ligament and the uterosacral ligament. Okay, those are kind of the strongholds of the vagina. And I attach the vagina to those ligaments so that the vagina doesn't come back down again. And when we do an abdominal approach, that's usually a second procedure if patients fail the vaginal approach. And that is when I will use mesh to kind of go around the vagina, and I attach the mesh to the anterior longitudinal ligament on the sacrum, and that holds the vagina up. And that is associated with a very, very low recurrence rate, but I am using mesh for that procedure, mesh augmentation. So that is it.
So because we're not going to have a panel discussion at the end because of our numbers, we can take questions now for Dr. Gagnon. Yes.
I have a question. All the speakers spoke about the importance of education and educating the public at large. And I read a lot, and I have not seen any literature in display in my doctor's office. I have not seen any literature in the Rexall or the Shoppers Drug Mart. I don't know why you are not producing fairly simple pamphlets that thereby you can educate the public at large.
About incontinence and
So I'll just repeat the question. Just about.
Something as simple as incontinence, and you could discuss some of the, like, for example, are you going to the bathroom more than 4 times a night? You can ask somebody that, and that's a question they can answer quite easily. It's not sophisticated, and they can determine whether that's normative or not, because I don't know what's normative or not.
So just for the audience purpose, the question was about the availability of education around all of these issues related to incontinence, and that could be accessed by the public. You could speak into the mic.
Yeah, I'm happy to answer that. I think you're right. I think there's a lot of work that we can do in education. I think in our office, there's a ton of information about incontinence and prolapse that's all over the walls, but we are a urogynecology office, so I don't think that's around a lot of other physicians' offices. We publish a lot of literature looking at incontinence and prolapse, but you're right. I think for a long time, this is not something that was talked about. It's not something that women talk about amongst themselves, and it's not something where there's been a lot of education that's been done around prolapse and incontinence, and you're right, that has to change. Do you want to say it, Judith?
Yes, go ahead.
I've heard that stem cell research could also be having you pursue things. I guess that was not there yet.
So the question has to do with the stem cell research and what role it might have in this issue.
How it could pertain to
I can talk about that because we did do some stem cell research when I was in fellowship. We conducted a big study looking at whether we injected stem cells in the urethral sphincter to see if it helped with symptoms of incontinence, and we didn't find any positive results with that. So didn't really hold. We performed a randomized control trial that we published. So yeah, I mean it is. We should probably do more research. It's probably an avenue to look into, but the preliminary studies that we did didn't really show much in terms of results. So.
Urinary catheter. We advise to take out the urinary catheter, which still has a pain.
So the question has to do with an older woman who has mesh implanted, and as a result she has some pain issue.
Yeah, so there have been issues with mesh. I didn't train in the era where we put in transvaginal mesh, but there was a time before my time where a lot of even general gynecologists were putting transvaginal mesh in for all prolapse patients and for all prolapse surgeries. And there's huge problems with that, and there were a lot of lawsuits with that kind of came around putting mesh into those patients. And the lawsuits were all around a lack of informed consent. So patients were not told about the risks of mesh, including pain. The mesh that we use for incontinence procedures has been around for a long time. It's also very easy to remove because it's a ribbon of mesh. It's not, so if patients end up with pain, you can easily remove it. But the old mesh that we were using that was for transvaginal procedures was almost impossible to remove. So there are a lot of problems with that. Yes, it can be associated, there can be pain associated with mesh implants. And so, yeah, there have been a lot of problems with all the mesh that's been used over the years for prolapse surgery, and it's not mesh surgeries that we do anymore. But there's a generation of people where mesh was being used quite a bit.
I wanted to ask Dr. Gagnon a couple of questions. One was, is collagen still used as something to inject into the urethra? And my second question is, for patients who are using the medications, how long should they persist to achieve the full benefit?
Okay, so we don't use collagen, but we use something that's similar to collagen, and that's used for intrinsic sphincter deficiency, so ISD. It's called urethral bulking. So we use a variant of that. The outcomes with periurethral injections are not great. So they work initially quite well, but they don't last. So the patients are good for a year, maybe 2 years, but then the symptoms the improvement kind of wears off. So I kind of I use it as a last resort. The other thing is it's not covered, so it's about $2,000 per injection. So I use it as a last resort, but it's definitely not my go-to. And you have to demonstrate intrinsic sphincter deficiency. So it's not for hypermobility of the urethra. It's for kind of a subclass of people with stress incontinence. And the second question was how long should people persist? I give people 3 months. So when I start a medication for overactive bladder, I give them 3 months. I see them in my office in 3 months. If they're seeing no improvement at 3 months, then I will consider changing the medication or adding a second medication.
Are there any other questions from our in-house audience? No. Oh, yes, one more. So just a question about Dr. Gagnon's office access.
B725, it's where the Urogyne division at Sunnybrook.
Okay, one more question.
Do you have any literature that we could take away tonight, like just generic, just points, bullets? I tried to take notes. It seems very fast.
I know, I did move fast. There's a time limit, so yeah. I don't have anything with me. I have lots of stuff upstairs in the office, but I don't have anything with me now.
If I could just play it, the topic
you. Thank you. So thank you very much, Dr. Gagnon. This concludes the presentations for tonight. We were not having a formal panel because of the storm has affected our numbers. But I wanted to thank all of our incredible speakers for their great presentations this evening. Before we finish, I'd like to mention that it's important to recognizing the importance of learning from our patients. We want to remind you of our weekly Sunnybrook blog called the Personal Health Navigator. It's written by a former journalist, Paul Taylor, and published on our website. The blog provides advice to patients about the hospital and their health care, relying heavily on medical and health experts. You can send your questions to askpaul@sunnybrook.ca. Special thanks to all our speakers, and we encourage you to visit the Sunnybrook website, www.sunnybrook.ca, for updates. And thank you once again for coming, and thank you once again for joining us online. Thank you.